Today I want to tell you a little bit about what's going on in reproductive endocrinology and some of the advances that have occurred in the last few years. And I'm going to do that in the context of teaching you how it works. I've always taught that way. If you understand how something works, then you're in a position to understand if it doesn't work or how to improve it. So we're going to do a little basic science at the beginning of this and review some things. Then we'll talk about some more interesting things and controversial things. So this is kind of an overview of what we're going to talk about. And we'll start with the story of eggs. The eggs in a human originate at the 3-week embryonic stage. And they originate in the yolk sac. And they migrate by amoeboid movement through the yolk stalk into the gut and up into the gonadal ridge. And the sperm follow the same pathway. And once they get to the gonadal ridge and they seed the gonadal ridge, they form what are called primordial follicles. And they multiply rapidly to reach a maximum number of about 5 million when the little female embryo is in her mother's womb at about 20 weeks. And there are no new eggs after that time. All the eggs are made by the 20th week of gestation. These are now called oocytes, and they're surrounded by a single layer of granulosa cells, and they form what's called a primordial follicle. The oocytes then enter the first meiotic division, and then that arrests, and it never resumes until the time of ovulation many years later. And that's probably one of the reasons why, as women get older and older, and their eggs have been around longer and longer, that those eggs don't work as well anymore, and we start getting certain disorders of egg division and some birth defects and things like that, which I'm going to talk about in some detail. Now, at the first meiotic division, and don't get scared by this because I'm going to walk you through it, the meiotic division is purposed to reduce the number of chromosomes in half so that we get half the chromosomes from the egg and half the chromosomes from the sperm, and then add them together, we get the whole again. So we have to get them down to half. And that's done by, first of all, each chromosome, and this represents a pair of chromosomes, so this might be chromosome number 1 from your father, chromosome number 1 from your mother. First of all, they duplicate themselves, but they stay hooked together. So actually at this stage, there's 4 times as much, or twice as much DNA as there is in an adult cell. And then those chromosomes pair up, and they touch each other, they form a chiasma, and they cross over. And this is a very interesting thing. Actually, there is pieces of chromosome that exchange. So a little piece of your father's chromosome will exchange with a little piece of your mother's chromosome, and then the new chromosome is a hybrid of your mother and your father. So the number of possible combinations of people that can be made are almost infinite. And then these then arrest at this stage, and they don't change until the oocyte is actually ovulated, and as I said before, that could become years. In fact, the signal that reinitiates the resumption of this division is the LH surge that occurs at the time of ovulation, and it signals ovulation. And when meiosis resumes, then the meiotic spindle forms and then pulls the chromosomes to each side, and we get then 2 cells that are identical that have half as many chromosomes. Now in the meantime, we said at 20 weeks we had the maximum number of these little primordial follicles. And starting at 20 weeks and continuing all during life until the eggs are all gone at menopause, every day, every hour, every minute, some of these little primordial follicles are differentiating and forming primary follicles. This goes on whether you're pregnant, whether you're taking birth control pills, whether you have periods or not. It just goes on all the time. The oocyte still remains arrested, isn't doing anything. Follicle gets a little bigger, and the oocyte gets a little bigger. And so there's a process where these little original follicles, called primordial follicles, become primary follicles. As I said, this is continuous from 20 weeks until menopause. It's independent of FSH and LH. It goes on during childhood. It goes on during lactation, all the time. The rate is proportional to the number of follicles. So the more follicles there are, the more of them make this transformation. The oocytes are arrested, and as I said before, there are no new follicles after 20 weeks. And what happens to these primary follicles? Well, most of them are lost. They undergo atresia, which is another name for apoptosis, unless they're exposed to FSH. Now, they're not exposed to FSH very much of the time. Little girls don't have much FSH. Pregnant women don't have much FSH. FSH only occurs at certain times of the menstrual cycle, and I'll tell you all about that in just a little bit. So if you look at the number of these follicles in life, at birth, the number of follicles has reduced from 5 million down to only 1 million. By the time the girl has her first period, there's only 300,000 of them left. By the time she goes to medical school, she's got 100,000 left. By the time she's done with all of her training and gets her life in order, she's only got 30,000 left. And things are getting a little inefficient by that time. And then by menopause, the number is essentially zero. There may be 1,000 or 500 or something like that, but they're essentially all gone. Now, this happens in many different species. For example, it happens in hens. And all of you farm people know that your hen doesn't lay eggs as well as she gets a little older. And finally, unless you're going to run a retirement home for old hens, you transfer the hen from the laying cage to the pot. Okay? I know something else about hens. I heard this the other day from Abraham Lincoln, was quoted as saying this. He was discussing his generals and how they were always bragging about what they were going to do, but they never did anything. And finally he hired Grant, which got the job done for him. He said, the hen is the most sophisticated creature in all of creation. She doesn't cackle until the egg is laid. That will grow on you in a minute. Now, once we get exposure to FSH, then, these primary follicles then can go ahead and develop, form a cavity, and then eventually reach the pre-ovulatory stage if they get enough FSH. And our oocyte is still in that pre-ovulatory stage in the first meiotic division. So primary follicles then, if they're given FSH, they can form antral follicles, which have a cavity, and then they can get bigger, and some of them can actually get to the Graafian follicle, or the follicle that will actually ovulate. And if at any time in this process, any time from this first stage here, now this stage, remember, is automatic, goes on all the time, has nothing to do with anything. Once you get here, you've got to have FSH, and as soon as the follicle runs out of FSH, it dies. Okay? So it's kind of a race to see who can get from here to here, because the amount of FSH is limited. There's not enough for everybody. This just shows an ovary that's about to ovulate, and it contains a single pre-ovulatory follicle, and the pre-ovulatory follicle is about 1 inch in diameter. So every woman has an ovarian cyst in her ovary every month, about 1 inch in diameter. And these are follicles, these are antral follicles that didn't make it. They started the race and they lost out, and some of these maybe didn't get as far. This is the ovary here altogether. So how does ovulation take place? What makes ovulation occur? So that's our next story here, the story of ovulation. I'm going to walk you through this. It's really pretty straightforward. The hypothalamus is just basically a collection of little neurons. Those little neurons produce a unique small peptide called GnRH. They produce it in pulses. They begin producing it at puberty. And that's really what causes puberty, is these little neurons start to fire in pulsatile fashion. And that then allows the pituitary gland to produce FSH and LH. Now, the main feedback loop here that controls most of the cycle is between the pituitary gland and the amount of estrogen. It's a classic negative feedback loop. That is to say, when FSH goes up, estrogen goes up. When estrogen goes up, FSH goes down, and vice versa. LH is involved in producing androgens in the ovary, which are necessary to make the estrogens, and then it causes a unique signal at the time of ovulation, which we'll talk about in a little bit. If ovulation occurs, we get a corpus luteum and a placenta. You cannot get a corpus luteum without ovulating. You can't get a placenta without ovulating. And progesterone is the unique hormone made by the placenta and by the corpus luteum. So progesterone is never made unless you ovulate. If you ovulate, you make progesterone. If you don't ovulate, you don't make progesterone. And then progesterone does have some feedback effects on the pulse frequency and pulse amplitude of GnRH, but that's really just kind of a fine-tuning thing. For the most part, the cycle is regulated right here between FSH and estrogen. So here are the hormone levels of the menstrual cycle. I often ask the medical students, I say, how come the menstrual cycle in women is 28 days? And I get various answers. Well, you know, it has to do with the phase of the moon, or it has to do with women living together, it has to do with who knows what. And I tell them the answer is because that's how long it takes. And that's true. The menstrual cycle can be divided into 4 different weeks. Each of these things take about a week to occur, and when you add them together, they take a month, 28 days. And they feed on each other. They succeed each other and precede each other, and it just sort of runs on autopilot. Once you have enough GnRH just sitting up there making the whole thing available, and you have a good pituitary gland and normal ovaries and so forth. So the first week of the menstrual cycle is where we select which follicle will get to win the race. The second week is where that follicle begins to produce lots of estrogen, and then it ovulates. There's a big surge of LH here that makes that happen. We'll talk about that in a second. And then the corpus luteum forms, and the corpus luteum takes 1 week to reach a maximum in its secretion. And if pregnancy occurs, the corpus luteum then begins to continue to make estrogen and progesterone, and that goes on up here until the end of pregnancy. If pregnancy does not result, then the corpus luteum fizzles out, undergoes apoptosis, and the hormone levels crash back down, and the cycle is over. And the withdrawal of the hormones at the end of the cycle is what causes the release of the support of the endometrium, and we get then menstrual bleeding at the end of the cycle. Now, I'd just like to point out some relative estrogen levels here just for fun. It turns out that a normal woman has an estrogen level during her period exactly the same as she would if she was menopausal. Every normal woman has a menopausal level of estrogen for about a week during her period. There are reasons why she doesn't have hot flashes. That's beyond the scope of this discussion, but she doesn't. The second week we notice the estrogen level peaks here at about 300 picograms per milliliter. 300 picograms per milliliter. And most of the time, the estrogen level in the menstrual cycle is between 100 or so and about 300. A birth control pill is a supraphysiologic amount of estrogen, and it produces an estrogen level of about 500. And that high estrogen level shuts the FSH completely off, and that's why we don't get any follicle growth and we don't get any ovulation when we take birth control pills. Just by way of comparison, a pregnant woman has an estradiol level of 5,000 to 10,000. That's probably up there 100 feet in the air on that same scale. So pregnancy has a tremendous amount of estrogen associated with it. A postmenopausal woman has an estrogen level of about 20. And if you give her a little dab of estrogen in a pill or a patch or something, and raise her estrogen up to about 50, she feels just great. She doesn't have any hot flashes and so forth. And that 50 is supposedly dangerous, but it probably really isn't that dangerous. So going from 20 to 50 makes her happy. We let her have 100 to 300 all of her life, and we let her have 10,000 when she was pregnant. So estrogen's really not poison. It's just part of the whole reproductive scenario. But I thought you might be interested in some of those levels. By the way, a lactating woman has estrogen levels of about 20 as well. A little girl has about 20, and so forth, just to give you some comparison. And we said that the feedback between estrogen and FSH is a negative one. That is to say, when FSH rises, estrogen rises. When estrogen drops, when estrogen drops, when estrogen drops, FSH rises. And so the menstrual cycle sort of begins here at the end of the previous cycle when the estrogen level drops way down and the FSH starts to rise. Now, every day, some of those little follicles have made that first jump and they're available. They're recruitable. And that depends on how old you are. So the average woman who's 20 years old has about 20 follicles available on any given day to run the race. And as she gets older, she has fewer and fewer follicles. And the race to become the follicle that will ovulate starts with the rise in FSH at the end of the previous cycle, right here. So now that FSH is up a little bit, the follicles say, wow, there's some FSH, let's start to grow. And they start to grow. And the bigger ones that get a little ahead just by random, they can grow a little faster. And the ones that don't keep up start getting less FSH because it's competed for. There's only so much. And so pretty soon there's only a few that have enough FSH and all the rest of them have dropped out. And by about day 7 or 8, we have a winner. And now the estrogen level starts to come up because that follicle is making more estrogen, and now the FSH is turned off even more to make sure that we only get one egg to ripen each month. Now in older women, there's fewer eggs, and so the race can be decided sometimes in about 2 or 3 days instead of a week, and sometimes there's enough FSH for a couple of follicles. So as women get older, they have shorter cycles. You've all noticed that. Women in their late 30s, early 40s will have cycles that'll shorten down a little bit. And twins are more common in older women for that reason. So it's a race to see who wins. And again, the FSH drops as the estrogen comes up. This follicle now that's making all the estrogen, that's the winner, over just a period of a few days, the pituitary gland senses all this estrogen. And there's some complicated mechanisms into how this works, but suffice it to say, this results in what we call a positive feedback loop. Whereas to say, when the estrogen goes up, instead of it shutting off the LH, it actually causes a sudden spike in LH. We call that the LH surge, and that's the signal for everything to get going again. The LH surge causes resumption of the first meiotic division and starts the second meiotic division, which I'll talk about in a little bit, and it arrests about 3 hours prior to ovulation. The LH surge causes ovulation, causes the follicle to rupture and be released, the egg to be released, and the oocyte now contains 23 duplicated chromosomes, and the first polar body contains the other 23. We'll talk about that a little more in a second. The oocyte is now said to be mature and capable of being fertilized, and we complete the second meiotic division only if fertilization occurs. We'll talk about that in a second as well. So here's a mature oocyte, and you can tell that because it's got a polar body. It's finished the first meiotic division. An immature oocyte doesn't have that yet. Okay? A mature oocyte can be fertilized. An immature oocyte cannot. A mature oocyte can be frozen and preserved for many years, and we'll see a little later that that's a new advance. Not only can we preserve embryos, but we can freeze mature oocytes for women who have cancer or for women who want to delay having children until they're 40 or 45. We can freeze a bunch of eggs when they're 25 or something like that. That's standard of care these days. The oocyte is also surrounded by a membrane called the zona pellucida. It's a complex carbohydrate substance, and its job is sort of to protect the egg from being fertilized by more than one sperm. I'll talk about that in a second anyway. So a mature oocyte likely is released in virtually every menstrual cycle. But pregnancy does not occur in most cycles. In fact, here is the chance of getting pregnant with 1 year of unprotected intercourse at various ages. From age 20 to 24, after 1 year, 85% of the couples will be pregnant, and that works out to a 15% chance of getting pregnant on any given month during that year. By the time you're 25 to 29, that's gone down to 12% a month, 30 to 34, 8% a month, 35 to 39, 6% a month, 40 to 44, 3.5% a month, and then 45 to 49, less than 1% a month. So people don't get pregnant very easily as they get older. We've already said that. And not only that, they're more likely to lose the pregnancy. This is the spontaneous abortion rate or miscarriage rate with various ages. And you can see here the baseline rate is 10 to 15% in young women. And after age 35 or so, it starts to go up so that by 39 or so, it's in the 20s. By 40 to 44, the miscarriage rate is 50%, and after 45, the miscarriage rate is over 90%. So let's talk about fertilization, early embryonic development, and see how all of these things fit together as we go a little further. Why doesn't a baby result from most ovulatory cycles? First of all, the fertilization failure may occur, and we don't really know how often that happens. Probably not too often. Embryo transport failure. The embryo doesn't get in the tube right, it doesn't get delivered to the uterus, washes through the uterus for some reason. We don't know how often that happens either. We know that the failure of implantation, that is the failure of the embryo to stick to the uterus after it gets there, is pretty high, probably at least 25%, even with normal embryos. So you put a normal embryo in the uterus, it still fails to implant 25% of the time. And then even more likely, even in healthy young people, it's very likely that at least 40% of all embryos are abnormal, even more with aging, and they either don't implant, or if they do implant, they don't have what it takes to continue to develop normally, and they just are lost. And we don't even know they happen. We have ways of looking at early pregnancy now with sophisticated HCG assays, and we know that occult pregnancy occurs much more frequently than we think. And of course, there can be complications of pregnancy that can also result in something happening to the baby. So here's our follicle that has now ovulated, released the egg. Here's our unfertilized egg. The second meiotic division is in progress here. The spindle is there from the metaphase of the second meiotic division. And the egg is picked up by the end of the tube fairly quickly. Usually the end of the tube sweeps across the ovary, and the cells on the surface of the egg are called the corona radiata. They're granulosa cells. They make the egg sticky. The tube can pick that up and grab it, and it pulls it into the outer part of the tube, where the sperm, of course, come up here. Now, the egg is fertilizable for about 18 hours. The sperm lasts about 3 days. And it's better to have the sperm waiting for the egg than it is to have the egg get in here and get tired and then have a sperm come get it. So the ideal frequency of intercourse is 2 or 3 times a week. And most young couples will have intercourse 2 or 3 times a week. I've asked that question of thousands of infertility patients, how often do they have sex? And most people have sex 2 or 3 times a week, depending on where they are and whether they're in medical school or residency or not, perhaps. But even then, they do pretty well as they're younger. They may get a little less as they get older. So timing is usually not the issue for getting pregnant, unless the frequency of intercourse drops down to once a week or something like that. And then we can use an LH test kit to look for that signal and time it correctly. The sperm undergo a reaction as they get into the uterus and cervix called capacitation, and it makes them able to actually drill a hole in this membrane called the zona pellucida, and they drill it by actually scything back and forth. They have special motility, and they cut their way through, and actually cut their way diagonally, so they leave kind of a diagonal hole so that nothing can come out of the egg. And the instant that the first sperm gets inside the egg, there's a block to all the others. The zona pellucida the little membrane around the egg, it just shuts itself down and there aren't any openings anymore. And so we only get one sperm, period, one sperm for fertilization. And that's good. You put 2 or 3 sperm in there and we have too many chromosomes and all kinds of chaos results. So here's our fertilized egg now. The female part of the DNA is still separate from the male part of the DNA. The sperm loses its tail. These special cells fall off now because they aren't needed anymore. And now the tube starts to transport the egg into the uterus. The first thing that happens is that the 2 pronuclei, that is the male DNA and the female DNA, actually stay separate for a day or so. And if you look at an early embryo, you can see those 2 pronuclei. Now you could argue that this is not a unique person yet because the DNA has not fused. So we're about 24 hours after the sperm has entered the egg here at this point. We still have our zona pellucida here, and we still have these pronuclei. So the first thing that happens then is that the first mitotic division, where the cell divides for the very first time, using the male and the female DNA, now we have a unique individual here at this point after the first mitotic division. And then the cleavage stage follows rapidly in the next few days. It takes just a little less than 1 day for each division to occur. So after about 20 hours, we have 2 cells, another 20 hours, 4 cells, 8 cells, and so forth. And these are called cleavage stage embryos. Every one of these cells is the same. Protein synthesis really isn't occurring here except in a very narrow way to just duplicate the cells. These are what we call embryonic stem cells, if you kind of want to know what an embryonic stem cell is. And that's because these cells are totipotential. That is to say, each one of these cells can make the whole package. Each one can make the whole package. They haven't decided yet who's going to be the lung and who's going to be the heart and who's going to be the brain and so forth. That all happens once the genetics kicks in at the end of the cleavage stage. At the very end of the cleavage stage, the embryo is maybe 16 cells. It's called a morula. It's been about 3 days now since fertilization took place. This shows the egg actually going through the tube smoothly, but actually the embryo parks itself here at the ampullary isthmic junction for most of the time and just sits there and then finally gets pushed into the uterine cavity at about 3 or 4 days. At that time, it forms what's called a blastocyst. The blastocyst is a hollow mass consisting of what will be placenta, still have our zona pellucida, and what's called the inner cell mass, which will become the embryo. Okay? And there may be 200 cells or something like that in the blastocyst. And then at this stage, the blastocyst hatches. And then what it means is that the zona pellucida is broken through. The blastocyst actually gets through the zona pellucida, leaves it behind, so it hatches out of its shell, and now it's ready to attach itself to the uterine wall and implant and become a pregnancy. And once it implants, then the HCG that it's been producing gets to the mother's bloodstream, and you can detect it by doing an HCG test, a beta HCG test, which becomes positive on about day 22. So this is day 14, and this is about day 17 or 18, and then this is about day 21 or so when we get to this stage here. This is a picture of one of the Carnegie embryos. Some pathologists in Boston sectioned hundreds of uteruses and hundreds of surgical specimens, and they didn't know who was pregnant and who wasn't back in those days. So some women had a hysterectomy when they were pregnant, and they actually, nobody knew that because you couldn't tell until 40 or 50 days back then. And they looked through the uterus very carefully, and they found some embryos. Some were normal, some were abnormal, and that constitutes what's called the Carnegie collection of embryos. I think there's 82 embryos in that collection. It took place for over a 14-year period by some interesting people. John Rock, particularly a Boston gynecologist who really did most of the work on developing the birth control pill in the late 50s and the early 60s. So this is a remarkable picture here of an early embryo. Here's the placenta out here. You can see we're starting to get some lacunae already for the intervillous space, and then here is the inner cell mass, which will become the embryo. And the top, the uterine lining, is just barely beginning to close over where this embryo has actually invaded inside the wall of the uterus. It's a remarkable picture, really. So that's how pregnancy occurs. That's some of the things that have to happen. Why is IVF so good today? Well, first of all, why doesn't pregnancy occur in most cycles? We already talked about that. Failure of fertilization, embryo transfer, implantation, abnormal embryos, and so forth. In IVF cycles, we confirm fertilization. We get to see that 2-pronuclear embryo. We know that fertilization has taken place. We know that the embryo is delivered to the uterine cavity because we put it there ourselves. We use ultrasound to guide us. We watch it go into the uterine cavity. Implantation failure, we don't know so much about that, but that does occur in IVF as well because the pregnancy rate's nowhere near 100%. We also know that a normal embryo is much more likely because we have ways of looking at the embryo and picking the embryos that are more normal. And then, unfortunately, we've started using many embryos. I mean, you put 2 embryos in, the odds are twice as good as if you put 1 in. So we've put lots of embryos in, and that's been responsible for the well-known spike in the number of twin pregnancies. So the goal of IVF in the last 20 years has been to try to figure out a way to reduce the number of embryos that we put back in the uterus down to 1 or 2, preferably just 1, and try to get the normal twin rate back down to 1 or 2% instead of what it is today. But that does make it more likely that somebody's going to get pregnant. Now, in the United States, everything's very competitive. The results of various clinics' outcomes are published, and you can get that online for every clinic in the United States that's doing IVF, and you can compare. Well, everybody wants to have a high pregnancy rate because that means that the patient might be more likely to come to your center than to somebody else's center. Since this is a cash business, it's very competitive, there's the potential for some abuses. The data can be manipulated subtly. All kinds of things can happen, and I'll talk about some of those things in a little bit. So if you look over the last few years, this is a graph of the live birth rate from IVF from about 2003 to 2013 by age. You can see that the pregnancy rate here, or the live birth rate in IVF cycles, is up around 40% in 25-year-olds, or people under 35 actually. Remember I showed you before that that was only about 10 to 15% in normal people. So we're tripling the pregnancy rate of normal people by doing IVF. That's what we're doing really. The multiple pregnancy rate, unfortunately, has stayed very high, particularly in those young people. It's come down some. It was 40% in 2003, and by 2013 it was down to 30%. And I have some additional data in a second. This shows the number of embryos transferred, and you can see that at all ages the number of embryos is coming down. So in an average woman under 35 now, instead of transferring 2.6 embryos, we're transferring maybe 1.8 embryos. So that has come down as of 2013. Now this is the latest data that's available, the data from 2017. 488 clinics in the United States, and those basically are all the reputable IVF clinics report to this database. You can see how many IVF cycles are done in women using their own eggs. 50,000, 80,000, 110,000, close to 150,000 cycles a year are done. And this is the percentage of people who start cycles who end up with a live birth. It's over 50% now in women under 35. That's how good IVF is. Women under 35 on their own have about a 10% chance of a live birth with one cycle of exposure. We're up to 50%. And the multiple birth rate has come down significantly between 2013 and 2017, down to only 17%, which is still a lot, and in older women it's still even higher, still fairly high. So how do we do that? How do we get the number of embryos down and so forth? Well, these are some of the controversies. Some people say you should never transfer more than one embryo, and that might not be a bad idea. Some countries have a law that says you can only transfer one embryo. We've developed some sophisticated ways of evaluating embryos, and I'm going to spend quite a bit of time about that. And that fits in with embryo freezing and some of these other things as well. So, does the embryo develop normally in culture by watching it? 50% of the embryos survive to the cleavage stage. That means 50% of the embryos that we fertilize don't make it to the 8-cell stage on day 3. And 30% of programs now transfer on day 3 when the embryo is 8 cells. If the embryo has what it takes to become a blastocyst on day 5, it's much more likely to be normal, because after all, it had to keep on going, keep on making everything it needs to make, and if something was wrong, then it would quit growing and it wouldn't make it to that stage. So just the fact that it gets to be a day 5 blastocyst is very important in terms of picking a normal embryo. Does the embryo look normal? We usually do that just by looking at it under a microscope, and there's a couple of new things that have been tried and probably don't work very well. One is time-lapse monitoring. You can actually put a little camera in your incubator and take a time-lapse picture of all the embryos. You don't have to touch them and look at them, and you can watch them grow in slow motion, and you can see who's growing normally and who's not dividing right and so forth. But that actually has not worked out to be a practical way of doing it. You can analyze the fluid that the embryo is growing in. It's called metabolomics. You can look at the fluid and see what the waste products of the embryo are. If the waste products of the embryo are abnormal, then that means the embryo is not likely to be growing as well, and you can select embryos that would be healthier, because the whole idea is to select the very best embryo that you've got and then put that embryo back in the uterus. In an average young woman, it's not unusual for us to get 10, 15, 20 embryos in a normal IVF cycle. And of course that number goes down with the increasing age. So we have to have a way to pick the best embryo. The really hot thing today is called pre-implantation genetic testing for aneuploidy, PGT-A, pre-implantation genetic testing for aneuploidy. How do we do that? Well, first of all, what is aneuploidy? In the meiotic division, we start out with an egg, and it's duplicated its DNA. So each chromosome has a double strand. So this might be a pair of number 1 chromosomes, and this might be a pair of number 3 chromosomes, or any 2 numbers you want to pick. And in the first meiotic division, normally what happens is that one of those chromosomes goes one way and one goes the other way. So here, at this first stage, you have an egg that contains maybe the chromosome that you got from your father and this chromosome that you got from your mother, and the polar body contains the others. And the polar body, remember, is just sort of lost in the egg. Then the second meiotic division, these cells then divide, and the 2 halves then go to the daughter cells. And so then this is now an oocyte that contains 1 chromosome from your father, and then this chromosome from your mother, and you mix that with a sperm and you bring it back to the full number again, and now you've got a normal individual. Well, something can go wrong in that, and it's called non-disjunction, where those chromosomes don't go equally to the daughter cells. So for example, in the first meiotic division, here's just 1 pair of chromosomes. Let's say that this is the number 21 chromosome. This is the 21 chromosome from your mother. This is the 21 chromosome from your father. And normally 1 should go each way, like this. But sometimes they both go this way. They both go to 1 cell and the other cell doesn't get any. When this cell is fertilized by a sperm that has 1 of those chromosomes in it, then the daughter cells, or the embryo that results, will just have 1 of those chromosomes. Most of the time that's fatal. Only 1 chromosome of any pair is fatal. The only time it's not fatal is really if there's just 1 X chromosome. We get an XO, and that happens sometimes, and that sometimes works. That can happen at the second meiotic division as well, and in this case here, you have 2 chromosomes, 2 number 21s in the egg. You put that with a sperm, now you've got 3 21s, and you've got a Down syndrome baby. And that's what happens when we get aneuploidy. So aneuploidy is basically the presence of an abnormal number of chromosomes in a cell. It's usually lethal, but sometimes it can occur and survive, and then these are the most common syndromes that result from non-disjunction in meiosis. Turner syndrome, Down syndrome, Klinefelter syndrome, so-called superfemale, another kind of Klinefelter syndrome, and a couple of the really bad trisomies that we hope not to see very often. So how do we look at that? Well, during the stage of embryonic development, while we have the embryo in the laboratory, we have a chance to take a biopsy of it, okay? And we could take the biopsy at the cleavage stage or at the blastocyst stage. This is a biopsy taken at the cleavage stage. This is an 8-cell embryo. We make a hole in the zona pellucida, the membrane, and we suck out a cell. Take 1 blastomere out here. Now, this looks like, this would be fairly easy, but I would remind you of how big this really is. This really is the size of a period on your paper. And so this is magnified a lot. You've got to have some nice equipment to be able to do this under a microscope. And our embryologists do this all the time in the IVF laboratory. And the idea here is that, remember, these cells are all totally potential. They haven't differentiated at all, so we should be able to take out a cell and leave the others, and we don't interfere with the formation of all the organs and so forth. The problem is that this does do some trauma to this embryo, and it's now been shown that biopsy at this stage is not going to produce anomalies. It's just going to make, for some embryos that don't survive it, it's traumatic to the embryos. So now we've gotten more to doing a biopsy at day 5 when the embryo is at the blastocyst stage. The blastocyst, again, here's the inner cell mass that will become the embryo, and this is all placental tissue. We call this trophectoderm. Here's our zona pellucida. We make a hole in it, and now we suck out maybe 7, 8, 9 cells, because this embryo is 250 cells or something like that. The problem now is that we're sampling the placenta cells. We're not sampling the embryo anymore. And so maybe the placenta doesn't reflect the same genetic constitution as the inner cell mass or the embryo. And we call that mosaicism. I'll get to that in a second. Now, if we're going to biopsy on day 5, it's going to take a couple of days for this to go to the lab and come back. And we have to transfer the embryo into the uterus at least by day 6. Because if we wait after day 6, the so-called window of implantation in the uterus closes, and the uterus will not accept the embryo anymore. So we've got to get it back inside the uterus by day 6. Well, if we're biopsying on day 5, and we take a couple of days to get the lab results back, we can't do that. So we end up freezing all the embryos. And that's what we usually do nowadays. We freeze all the embryos. Now that is really maybe an advantage, because when we put the embryos back, we're going to put them back in a more normal cycle. The cycle we got them from is a cycle where we stimulated the ovaries with lots of FSH. That's what fertility drugs do. They stimulate lots of follicles to grow. The estrogen levels are very, very high, and that may be somewhat toxic to embryos. So if we freeze them and put them back in a cycle where the hormone levels are more physiologic, it looks like that's going to result in better implantation rates than we get in a so-called fresh cycle. So that's something that's evolved over just the past few years. And again, part of what I'm trying to update you on. In addition, if we transfer in a cycle where we haven't stimulated the ovaries, we reduce the risk of ovarian hyperstimulation syndrome, which we don't see it very often, but it gets your attention if it happens. You're called during lunch to see somebody in the emergency room who's come in because she's in shock. And what's happened is her ovaries are about this big. Each ovary is about so big. It's leaking lots of fluid. She's got ascites and volume depletion, and it's a stormy course over the next few weeks. We can eliminate that by freezing the embryos and putting them back in during a fresh cycle. So how do we determine who has aneuploidy and who doesn't? Well, the genetic test for embryonic aneuploidy started with what's called FISH, fluorescent in situ hybridization. It's just a kind of a crude thing where you label some DNA segments that match certain segments on a chromosome, and you hybridize or let those DNA segments combine with the cell, and if they bind together, then you get a fluorescent probe, and it shows the cells, it shows how many chromosomes there are. And this really did not work, and we've abandoned this a long time ago. The current standard that we're using is something called next generation sequencing, NGS, or it's also called massively parallel sequencing. And most IVF programs now are doing this on all the embryos, and then they're freezing them and transferring the normal ones back. It has yet to be shown that this is completely effective. And one of the problems in reproduction is that when things come along so quickly, so I mean, we're talking about things that happen just in a year or two. So today's standard of care or today's things are obsolete next year, or there's something new next year. And so it's very difficult to do a proper scientific study to show what you've got because everybody wants to move on to the next step. So we're constantly behind in terms of trying to show the efficacy of these things. And then when you do a study, you publish the study 4 or 5 years later by the time it's done, and oh yeah, we don't do that anymore. Why'd you publish that? And it's difficult to stay up with the way things go in this field. In addition, there's some problems because it's a very competitive field, and it's financially very competitive and very rewarding. And so should you get the patient to pay for doing this? Well, most centers do. I mean, this is $1,000 added on to the cost of doing IVF. And does it make any difference? Well, maybe, maybe not. And there are a lot of things like that, and there's controversy all the time over what should be done and what shouldn't be done, and that's an ethical discussion that we could spend quite a little bit of time on. Anyway, what happens here is the whole genome of the embryo is fragmented into small pieces. Remember, we took this biopsy of the embryo. We've got these embryonic cells that came from the placenta. The fragments are randomly sampled, they're sequenced all together, the computer reassembles them, and the whole genome is sequenced. So you get a tremendous amount of data. You get the whole genome on every one of these little tiny embryos the size of a period. The whole human genome is available to you. That right now is TMI, too much information. We don't know what to do with all of that information, okay? So that's kind of where we are now. We're kind of sorting that out. What do we do with it? Well, for example, there's some issues with doing that. One of them is embryo damage. I already said that it was fairly significant in the 8-cell embryo and really probably minimal in the blastocyst at day 5. But mosaicism is the big problem here. So what's mosaicism? In mitotic divisions, the cells split into 2 chromatids, and then those are pulled apart to the daughter cells by the mitotic spindle. Sometimes when the mitotic spindle pulls those chromosomes to the new daughter cell, one of them gets lost in the shuffle. That's called anaphase lag. So this cell here is going to have all the chromosomes. This cell over here is going to be missing one. And we then end up with 2 daughter cells, one of which has all the chromosomes and one of which has missing one. This embryo is now a mosaic. That is to say, it has 2 different populations of cells. 2 different populations of cells. Now, in the case of most chromosomes, this is lethal. But some chromosomes, you can get along without one in some of your cells. And depending on when this occurs, if it occurred in the very first mitotic division, way back when the embryo was just fertilized, that would mean that 50% of your cells were normal and 50% of your cells were abnormal. And you might end up with a XXXO mosaic, which has implications. If that happened maybe at the 1,000th division, then you'd end up with 999 cells that were normal and only one that's abnormal, and all of its descendants are abnormal, and only 0.1% of your cells would be mosaic, and probably all of us are at least that much mosaic. Interestingly enough, when I teach this to the students, I tell them that all women are mosaics because you inactivate one of your X chromosomes in every cell. So half of your cells, in all you ladies, half of your cells are using the X chromosome you got from your father, and half of your cells are using the X chromosomes that you got from your mother. So you're really two different people, all of you ladies. It's okay, it works out all right, but it's an interesting something to think about. Anyway, so this occurs very commonly, and when the report comes back from the laboratory about what's going on here, we find that a lot of the cells are mosaic, and we don't know what to do with that. So sometimes we just ignore it. We don't even want to know. Or we want the lab to report if it's more than 40% mosaic or whatever. We use something. How would you explain this to a patient? How do you explain all that? Well, 20% of your embryo cells are mosaic. They're abnormal. What? It's not a normal embryo. Well, yes, it is. It probably is okay. Probably fix itself. So we'll go ahead and put that one in. Because if we took only the embryos that pass all the tests, there wouldn't be any embryos left. We'd never put anything back. Because every human embryo, by these criteria, every human embryo is abnormal to some degree. Now, nature has ways of fixing that, and so it turns out that most of us turn out fine. But it's confusing when we're starting to look at this very early stage. So there's some different add-ons that have been used to try to improve the effectiveness of IVF, and many of these really don't work out. They're assays to look at how receptive the uterine lining is. It's been thought that maybe if you scratch the endometrium with a little biopsy the month before, it would make it work better. There's a hyaluronic acid you can put on to make the embryo stick and all kinds of things. And all of these things are relatively ineffective when we start looking at studies. Assisted hatching's been popular. Remember, the embryo had to escape from its shell. We've figured out a way to drill a hole in the shell and let the embryo out easier, and it's thought that would take less energy and the embryo would be happier if it got out of the shell easier and so on, and that turns out that probably doesn't really do very much except in a few selected cases. So I want to close by just talking a little bit about preimplantation genetic testing for known genetic disorders, and then fertility preservation in cancer patients and aging women. Preimplantation genetic testing assumes that the parents would be amenable to not transferring an abnormal embryo. And then that raises, for those that are worried about when does life begin and what is life and so forth, does an abnormal embryo deserve a chance to become an abnormal baby? I don't know. Should it remain frozen until it's adopted? Well, who would adopt an abnormal embryo? Or maybe someday we'll be able to fix it. That's possible. Maybe we can splice the genes, the normal genes, back into an embryo, make it normal again. In some situations, we can determine whether or not there is a genetic disorder. So parents that are carriers of recessive disorders like cystic fibrosis, sickle cell, Duchenne muscular dystrophy, and so forth, or maybe carriers of the BRCA mutation, or maybe unaffected non-carrier embryos would be transferred, or maybe even sex selection might be useful. For example, autism has a 4-to-1 male to female ratio. So we can do those things. We can look and find the embryos that have the trait that we want to eliminate. We can transfer the embryos that don't have that trait, and therefore we can actually eliminate a hereditary disease from the family of that patient. And I've done that a number of times with cystic fibrosis and several other things. It's really great. You can take a family that's got that gene, a risk of that disease, and you can transfer an embryo that doesn't have the gene, and then all the descendants of that embryo are normal in terms of that gene, and they don't have that disease anymore. That's a cool deal. Sometimes you can, for example, we've done this a few times around the country. A couple wants to give birth to a child with a compatible HLA type for stem cell therapy of a sibling. That's not unethical as far as we know today, or it's not considered unethical, and it's done. And then sometimes a couple might wish to avoid passing an unconfirmed dominant disease like Huntington's. You know, you don't find out about Huntington's until you're fairly far along in life. You'd like to eliminate that. You don't want to know if you had Huntington's or not, so you can transfer the embryos without telling the mother or father if they were affected by Huntington's or not. And sometimes you might even do a mock embryo transfer, not transfer any embryos if they were all affected, just so you don't have to tell the person whether they're going to get Huntington's disease 20 years from now or not. So it gets kind of interesting, but we can do all of those things. And we can do sex selection. We have guidelines, and we don't usually do that electively. And in the future, perhaps we can look at all the different genes and find out, you know, we'll select genes for whatever we want to do and create a child that's just right and so forth. We're a long ways from that, but the ethics are there, and the issues are there and are being talked about and dealt with. And maybe we can even replace abnormal genes using the CRISPR technique where you can splice a gene into an embryo. Outcomes pretty good after all these things. Doesn't seem to be any major problems with birth defects or pregnancy complications within some discussion. And finally, fertility preservation in cancer patients and aging women. And I'm going to go to the aging women first. Fertility preservation and for deferred childbearing for non-medical indications. Medical student looking at residency knows that she's not going to be done with all that till she's in her 30s. Maybe doesn't even get married till she's in her 30s. She wants to save some eggs or some embryos so that she can have children when she's 40 or 45, because if she waits on her own, she will probably not be able to have children at 45 unless she uses somebody else's eggs. So today, the standard of care is we can actually do in vitro fertilization with embryo cryopreservation. Now this requires her to have a partner, either somebody that she's got a commitment to or a donor. But just in the past couple of years, we can do mature egg cryopreservation. We can save mature eggs. We have to stimulate the ovaries to get them, but those mature eggs can be frozen and kept for a long time, and then that woman can have children using the partner of her choice 10, 15, 20 years from now. That is available today. And that's available for your cancer patient as well. And it's available quickly. You can have a patient, for example, who's got a cancer. You want to institute treatment within a month. You can get this all done in 2 weeks. And you can start any time in the cycle you like. That's where we are today. That's available. You just have to know where to go to get it. And it's available at most IVF centers. So that's something you can do right away. You can do that on a cancer patient, or you can do it more at your leisure with a woman who wants to have children a little bit later. Immature egg preservation, we have not done very well yet. Only a handful of babies have ever been born taking immature eggs. Remember, an immature egg is one that's not been exposed to the LH surge. The LH surge causes the egg to mature, and we have to get an egg that's been stimulated and grown to a pre-ovulatory follicle before we can get a mature egg. So immature eggs are not very effective. Ovarian tissue and ovary cryopreservation, where you take out an ovary or take out a piece of an ovary or a slice of an ovary, that's still pretty experimental. In fact, it is experimental. And there are many, many issues there, particularly in cancer patients. You don't want to put a piece of an ovary in there. There might be metastatic disease in that piece of ovary, and so forth and so on. So the fertility preservation in cancer patients is pretty much the same as it is in the woman who wants to delay her childbearing until she's a little bit older. Same is true in men. You can get testicular tissue and preserve the testicle, but there again, you have the risk of having perhaps metastatic conditions in there as well. Okay, I'm out of time, and you're probably exhausted by all the stuff I told you. I hope I made it interesting for you so you understand how it all works and how the different things fit together. And it's a very exciting field. I've been part of it for my whole life, watched it go from when I had very little I could offer an infertility patient to now when I can, if you give me the price of a new car, I can give you an 80% chance of having a child.
Thank you very much, Dr. Patton. We do have some time for a couple of questions. Any questions for Dr. Patton?
Thank you.
I have one right here.
Up to your right here.
So with all the hormone stimulation in order to get the egg and things like that, is there any risk in terms of long-term effects in terms of maybe increasing risk of cancer or anything like that?
Doesn't seem to be a lot. You have to remember that a population of infertile people will have a higher risk for certain pregnancy complications and for certain embryonic problems over the average population. So you have to take that confounding variable into effect. And when you do, you find that probably there's not a significant risk in doing all these things.
One more question. Did you have a question? Did you have a question up here? No.
You know, when I was looking at the chart, there seemed to be several figures there for the chances of becoming pregnant, having a live birth.
Yes.
I think that's the figure that I've heard a lot is 50%, and then now I've heard you say 80%. Is there like an average figure out there? Is it still about 50? Is this what is that number?
The national figure, of course, it varies from age to age. The national figure in women under 35 now is a live birth in 40% of the cycles that are started.
Okay, so
40% of the
chance.
cycles. So if you do 3 cycles, you do 40% and then 40% of the 60% and then 40% of the that. You add that up and you get to be around 80% chance of a live birth.
Got it. And is the cost around $20,000 still?
It's probably a little less than that. Let's say 15.
Got it. Okay, and it's $20,000, and you would do it. Is that each time $20,000?
Only for the first time, because usually in a younger person you get enough eggs or enough embryos from the first stimulation cycle that you can do several frozen cycles, and those are much cheaper than doing the original stimulation cycle. So you can, in a young person, you do one stimulation of one egg retrieval, you can usually do 3 or 4 cycles out of that. An older person, you may not only get 1 cycle, or you may not even get any embryos that make it far enough to be transferred, the older you get.
Thank you very much again, Dr. Patton. Let's give him a round of applause.
Thank you.
Appreciate it a lot.